One, one. Hello, one. Hello, 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 hello. Check. One, 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 two, one. Come करो. Hello, hello, hello. One, hello, hello, hello. One, one, two. Hello, one. Hello, hello. Oh, testing. One. Check. One, two. उतर के लेके उसी के पीछे आके गाड़ी चली गई तो क्या करना लेके अभी बताया नहीं, बाद में बताऊंगा।
Good evening, friends. We welcome you to another episode of the PG Clinics webcast. Today we are broadcasting from Lokmanya Tilak Medical College, Sion Hospital. And the focus today is going to be on hematology. Before we talk about the clinic and the faculty, I would like to thank Wockhardt Vaccines for taking up the onus of giving us an academic grant for the PG clinics. We were away for some time and we are back because of their help, and we are really grateful to them. Mr. Sangram Shirke has been responsible for this, and from the entire team that's handling the PG clinics from the 3 metros, we want to express our gratitude to them. This program began as an action plan of the president of IAP in 2014, Dr. Vijay Evle. Because it was such a great success, it has been carried on into 2015 with the consent of the current president of IAP, Dr. Kamath. And I hope with this kind of a response, we will continue this clinic in the years to come. About today's clinic, the expert who is going to handle the case today is Dr. Mamta Manglani. She is the head of Department of Pediatrics at Sion Hospital. Her special interest, she is a hematologist, and I will not tell you more about how good she is. You will see as this clinic unfolds. So we are ready for a session on hematology, and I will request Dr. Kunal to come and present.
Thank you, sir. My patient Aryan Pandey, 5 months old male child, first by birth order, born of non-consanguineous marriage, Brahman by community and Hindu by religion, resident of Sion, hailing from Allahabad. History dates back when the patient was at the age of 1.5 months, when mother brought the patient with complaint of increasing pallor over last 15 days. And since history dates back to the early infantile age, I would like to start from birth history. This was born, the baby was born out of term vaginal delivery to a primigravida mother. Birth weight was 2.13 kg, and it was a registered pregnancy. Mother was vaccinated with 2 tetanus injection and took iron and folic acid supplements, but compliance was poor. USG abdomen done during pregnancy was normal, and no major medical illness in mother during or prior to pregnancy. No difficult delivery or prolonged duration of labor. Mother blood group was A positive and baby blood group was O negative documented. Baby did not cry immediately after birth. Born of meconium stent amniotic fluid. Required bag and mask ventilation for 3 minutes. And an ICU stay of around 1 month in view of neonatal jaundice with anemia. During an ICU stay, patient required ventilation for 10 days and was given packed red cells transfusion at day 1 of life. On day 2 of life, in view of neonatal jaundice, required exchange transfusion followed by phototherapy. Was given apart from this, patient was given IV medications, IV fluids, and after day 10 of life, patient start on breastfeed. At 1 month of life, patient was discharged from NICU on iron and vitamin D and calcium supplements and was hemodynamically stable with no pallor or jaundice. At home, patient was on exclusive breastfeeding, doing well except over last 15 days, noticing increasing pallor by the mother, but patient was active, playful and feeding well. No history of fever, jaundice, high colored urine noticed by mother. No history suggestive of bleeding from any side. No history suggestive of birth trauma. No history of abortion or stillbirth. No history suggestive of any hematological disorder requiring blood transfusion in family. No history suggestive of gallstones or any abdominal surgery in family. Since then, patient is on regular follow-up and received 3 more PRC transfusion at the age of 2.5 months, 3 months and 4 months of age. Currently on some daily intramuscular injection and gaining weight appropriately, and at present patient having no complaint. Immunized till date as per National Immunization Schedule.
Let us wait, Kunal. So let's analyze the history that you gave. You said that this baby had pallor on day 1, right?
Yeah.
And had required a transfusion, exchange transfusion on day 2 of life.
Yeah.
What thoughts come to your mind when you have a baby who's pale at birth and requires an exchange for jaundice and anemia on the 2nd day of life? So in maternal history you took some history, but could you take some more aspects into consideration?
Yeah, ma'am, I would like to rule out, apart from ABU incompatibility and RH incompatibility, I would rule out any membranopathy, enzymopathy in form alpha-thal can present.
No, I'm not asking you differential. I'm asking you in history of the mother's pregnancy, during pregnancy history. You would like to know any more things that you have not asked? See what you asked, what all you asked.
I asked for fever, jaundice in baby and
in the mother what you asked during pregnancy.
Ma'am,
antenatal history you asked certain questions, no?
Ma'am, was she taking adequate supplements?
Yeah.
And I would have asked for any infections in form of fever.
Right.
And rashes in mother.
So
and
I think let's do it other way. We'll come to your madam's first question, that if a baby needs a pack cell transfusion on day 1, what are your thoughts? She asked that, and then based on what are your thoughts, we'll go back as to what was missing in the... So what are your thoughts?
Intranatal bleeding like abruptio placenta and placenta previa.
Okay, so it could be a fetomaternal bleed. That's what you want to say? Okay. What is a fetomaternal bleed basically?
Bleeding come from mother side. So,
Fetomaternal.
Fetal
side.
Fetal side
to placenta.
Into the mother. Okay. What examination would have been very crucial for knowing this fetomaternal bleed? What examination would be crucial? Which we almost always tend to neglect and forget.
IAP test.
IAP test is for?
Please, those who want to speak, please raise your hand so that we can get the mic to you. So that
is not what we are suspecting here. We are not suspecting baby has swallowed mother's blood. We are suspecting baby has lost blood into the mother's circulation or into the placenta. Anybody else would like to answer? What would you like to examine in such a case?
To examine the placenta.
Exactly. You will like to know whether there was a retroplacental bleed, there was a abruptio placenta, there was any umbilical vein disruption, etc. So umbilical hematomas. Okay, umbilical cord hematomas. These you will like to know. So because baby's blood volume is how much at birth?
80 ml per kg.
80 ml per kg. So if it's a 2 kg baby, 2.5 kg baby, it's just about 200 ml max. So 200 ml may say agar even 15, 20, 30 cc's are gone into the mother, it's a huge amount for the baby. Okay, anything more than 10% will lead to problems. So you need to be aware of that blood volume related issues also, because you might wonder umbilical cord hematoma, what big deal? But it's a big deal. So keep in mind that you have to ask for placental findings if available. Yeah. What else?
So go through the maternal history which you said and give us a quick reason why you asked, and then quick.
Any infection during
No, that you said. So intrauterine infections, will they present with pallor on day one of life? Very, very unusual, very unlikely, but
Ma'am,
nevertheless.
there is a comment from the net.
Yeah.
They want to know whether if the mother has a parvoviral infection, will it lead to anemia?
Of course we will consider non-immune hydrops fetalis. One of the commonest is parvovirus infection in the mother transmitted to the baby, causing late trimester. Early trimester will lead to embryopathies. Late trimester will cause bone marrow failure like phenomenon. Yes, it will. So, yeah, you were saying something. I lost that thought.
The antenatal histories. So you were saying
Yeah.
infection, and we said
Yeah, so
infection
infection
will not.
very rarely will lead to day one pallor.
Erythroblastosis fetalis. Erythroblastosis.
That is what we were talking of right now as RH isoimmunization he talked of, ABO-RH. Now this baby's blood group is what? So is there a ABO-RH incompatibility? O negative baby, A positive mother.
Yeah.
Yes, no? No. Because both the antigens are missing, no? RH antigen is missing, O and ABO group antigens are missing in the baby. So obviously it is not ABO or RH incompatibility. But do you stop at that? Exactly. So there are so many red cell antigens which we do not test for, and those antigen incompatibilities can also lead to isoimmunization. We do not stop at that. Therefore, we do some testing, and that will come to later. What else? One major chunk of history you've not told.
Anybody from the audience?
Pardon? Drug intake. Which drugs? That's the next question, no? Which drugs you would be interested in knowing? Anti? They cause thrombocytopenia. They don't cause anemia. They cause thrombocytopenia. Sulfur drugs, okay. For aplasia in the mother, causing aplasia in the baby, not a very common thing. No, autoimmune hemolysis due to drugs in the mother. That antibodies can get transmitted to the baby and baby can develop that. Then any autoimmune disease in the mother, you should ask history of any rashes which were classical of SLE or APLA syndrome. So you asked history of abortions. So that will tell you APLA syndrome. APLA again causes more thrombocytopenia rather than anemia, but it could cause anemia also. So keep in mind these immune phenomena which can get transmitted transiently to the baby by the mother. Yeah.
So, ma'am, shall we ask them what is your analysis of the history that you have heard so far? So, day 1 packed cell required, then day 2 exchange transfusion required, and then baby discharged at day 10 and came back at 1.5 months with pallor.
Discharged at 1 month of life.
And sorry,
Came again.
came at 1.5 month with pallor.
Some kind of intrauterine hemolysis which has happened, that is why probably the child has received a PRC transfusion on day 1 of life.
So one thought is intrauterine hemolysis. Why? Anything is in favor of that?
The child has had a course of neonatal jaundice as well. So that is favoring
So your day 1 anemia is not the reason why you should think of intrauterine hemolysis. Day 2 exchange transfusion required for jaundice with anemia is more the reason why you should think of hemolysis. If I didn't know second day history, I would think of many different causes, non-hemolytic also, because only anemia. But now you have second day history of jaundice with anemia requiring exchange. That pushes us to think about hemolysis. Right? Any other thoughts? You've heard the whole history. So early on he had some hemolytic anemia. What happened later?
So why did this baby come back at 1.5 months? Any thoughts on that? would all normal babies also start becoming anemic at 1.5 months or later or what?
Physiological anemia of infancy usually comes at that age of 1.5 months, 8 to 10 weeks. And if it's a premature or a low birth weight child, it may be exaggerated. So the child's birth weight was 2.13 kg, which is low birth weight.
Okay, so physiologic anemia, anemia of prematurity, but he was a full-term baby, right?
Yeah, full term.
Though he was low birth weight, he was a full-term baby. So would a full-term baby come at 6 weeks with anemia of infancy or a physiologic anemia of prematurity?
And more so, will they present with pallor to the pediatrician? Means the hemoglobin may start dropping, but yes.
Significant pallor requiring again intervention in form of transfusions. Is that a common scenario with anemia of prematurity or physiologic anemia of infancy? It isn't a common scenario because anemia of infancy in a full term comes by 8 to 12 weeks first of all, not so early, right? So that is another reason why you won't suspect at 6 weeks a baby requiring transfusion. But given the past history of day 1, day 2, would you like to link it? Ongoing hemolytic process. So what kind of conditions will give you ongoing hemolytic process?
Please ask for the mic.
Hemoglobinopathy is
Mic is not working. Take.
Spell out the hemoglobinopathy. Qualify it.
thalassemia.
Qualify it further.
Alpha
Shakuntala, you are not
thalassemia.
allowed to speak. No.
Beta thal major, alpha thalassemia.
Alpha thalassemia I accept. Beta thal major does not present till 6
months of age.
Why it doesn't present?
Fetal hemoglobin.
Exactly. So you know the answer. So yeah. Then what else?
Enzyme defects.
Okay. So all your list of hemolytic anemias could have manifested at birth and then again might have come at 1.5 months. So you will need to keep all those in mind. List them quickly. Alpha thalassemia, enzymopathies,
Membrane defects.
membrane defects. What else? Any other? She said. This is a male child or a female child?
G6PD is male.
Male, so G6PD would be also included in the enzymes. Otherwise, PK alone, pyruvate kinase. Okay, I think these are the major 3 groups that you will remember. And of course, now you will think of torch infections also additionally. Because now the patient is ongoing having some problems. So maybe he had an intrauterine embryopathy with some problems of anemia at birth and now it is ongoing. So you will think of those things. But naturally examination will help you. Yeah.
Sorry, I keep interrupting.
No problem.
But in enzyme deficiency, there's a question where they're asking that if the baby or the fetus is G6PD deficient and the mother takes a drug which causes hemolysis, will it affect the fetus?
If the drug crosses the placenta without being metabolized and its metabolite is not known to cause the G6PD precipitation, then it will.
So
if the metabolite or the drug crosses the placenta and is the type which triggers the G6PD, then it will.
But ma'am, will it be little relative as in degree of deficiency, concentration of the drug, or it wouldn't matter?
No, that's why. So it should cross the placenta in the amount that
In
is
a good
required to
cons-
cause. Yeah, required to cause the precipitation of hemolysis in a G6PD deficient. Okay, I think
So,
their thoughts
but
are
now,
okay.
ma'am, multiple transfusions.
Yeah, I wanted to come to that. So 6 weeks was one transfusion, but monthly he required till 4.5 months, right?
Yeah.
He kept requiring transfusions. So is there any other condition which you will consider given the thought of first day and second day? History of the first and second day. Any thoughts? See, we talked of isoimmunization.
Delayed
We said,
isoimmunization.
who said that? Who answered?
Here.
Acha, you answered.
What did you say? We didn't hear you.
Delayed isoimmunization.
He is not supposed to answer. Okay, good. Delayed isoimmunization is a terminology which is an accepted condition now, and it is taken as one of the causes of anemia which persists or comes again after the baby has gone through the hemolysis in the early neonatal period with isoimmunization. This is commoner with RH isoimmunization rather than with minor groups, RH and ABO rather than with minor groups. But even minor group isoimmunization can lead to that. But we didn't have really a significant reason to only suspect that, because this baby required just one exchange transfusion. Is it common?
Can we allow him to explain that?
Yeah.
Can you explain what is delayed isoimmunization?
Some antibodies may have antibodies against IBC may have persisted in baby's circulation and may have manifested later. That is why a patient is requiring frequent transfusion, PRC transfusion at monthly interval. So the process has been for antibody formation has been started in during NICU stay, but it is manifesting.
Antibodies are formed
So
in
ma'am,
whom?
you please clear it.
Antibodies are formed in whom? Mother, and they are transported to the baby and transferred through placenta, and then baby has those antigens, and therefore the baby reacts and causes hemolysis. Delayed isoimmunization happens when the antibody doesn't get cleared off from the system, either because we have not adequately done an exchange transfusion. So that's one of the aspects why I was insisting on asking, with one exchange transfusion, do you manage generally these babies? Generally they require repeat if they have very high bilirubins. So that was one thing. And second day of life, when hyperbilirubinemia is there, obviously it worries. You can't allow the baby to remain without any treatment further. So in this case, the bilirubin might have got cleared, but did the antibody get cleared? Probably not. And this antibody can then persist for about 6 weeks to 3 months in the baby and lead to slow hemolysis, which may be ongoing. And then they manifest again and again till 3 months or so. By and large, by 3 months, the antibody gets cleared from the system, and then the baby becomes all right. Now, in this case, you heard that 3 months ke baad bhi he required transfusions till 4.5 months. Agreed, variability can be there, but then it becomes little less likely that this was just delayed isoimmunization. So, what further we'll hear the story, and then we'll know what happened to this baby.
Can we take a couple of questions here? There is one question. What about transient erythroblastopenia of infancy?
Transient erythroblastopenia of infancy seldom will manifest at birth. That's first thing. It is a condition which comes generally by 6 months to 1 year of age. Diamond Blackfan anemia is another close differential to the TEC, in which case it will be at 2 months onwards generally. Again, in Diamond Blackfan it can manifest on day 1, but you cannot explain the jaundice that came along with it. So if jaundice is there, my hypoproduction, blood loss anemias go out. Because in neonatal period, anemias are generally blood loss first or hemolytic. Production related anemias are highly uncommon, but if they happen, they would not be with jaundice. So this would clarify the...
So ma'am, when you said Diamond Blackfan on day 1 means it has started intrauterine.
Yeah. Which are severe forms, which are very rare. Whatever I have seen so far, Diamond Blackfan, maybe I've seen about 15-20 cases in my whole career. But they have all generally presented at 3 months, 2 months.
So it's after the nadir, and then when you're supposed to restart with erythropoiesis, that's when they start showing up.
Yes. Okay.
Go ahead.
Baby is immunized till date as per national immunization schedule, and developmentally all...
I want him to summarize the history and just give a little...
Sure, yeah.
Because I think we did not do that.
5 months old male child.
No. Summarize meaning? What are
Salient 3-4 lines.
This is a 5 months old male child which presented with significant pallor requiring PRC transfusion at day 1 of life, followed by jaundice requiring exchange transfusion at day 2 of life, and with the component of sepsis in form of prolonged NICU stay and initial ventilation for 10 days, followed by patient was discharged, but following discharge over 15 days patient again manifested increasing pallor.
One sec. What is the way to summarize? Anyone wants to attempt summarizing who heard the story? How will you summarize this in 4-5 lines? What happened to this baby? Come on, we have been doing it every Thursday. So try. Who wants to try?
Nobody wants to try. See, try here because trying in exam might be fatal. So try here. Yeah, ma'am.
This is a 5-month-old child who has presented with a day 1 history of pallor requiring a transfusion, and day 2 followed requiring a long NICU stay in view of sepsis query, and coming repeatedly with a need for transfusion every time. With no significant maternal history pointing to any particular cause for this anemia.
Okay. Okay, great. Was there jaundice in the following episodes after the first exchange transfusion on day 2?
Yeah,
Because did you say that history of jaundice afterwards?
after exchange transfusion, the patient required phototherapy for around.
No. In the episodes of
So
anemia which happened.
the PRC transfusion at 2.5 month, 3.5 month, and 4 months.
No, subsequent jaundice episodes are not
Now,
there.
this is a point all of you have missed and nobody has mentioned, that there is no jaundice in the following episodes. What does that tell us?
Hemolytic.
Hemolytic is in our mind when we hear that exchange transfusion. Don't get obsessed, because that might have been an episode of sepsis with hemolysis. We don't know, because there is history of a 10-day NICU stay with ventilation with sepsis history. So don't get obsessed by that. Think apart from that. So if there is no jaundice, what are the likely anemias? And if there was jaundice again and again with these anemia episodes, what are the likely causes? Yeah.
Ineffective erythropoiesis.
So in which condition?
Thalassemia.
Which thalassemia?
Alpha thalassemia.
Always say what you are wanting to say correctly. Alpha thalassemia therefore becomes a higher differential compared to the other causes, because you don't have jaundice again and again. But do you need to have jaundice in every other hemolytic anemia all the time? Do you need to have, suppose I say it is hereditary spherocytosis. Is jaundice a must with every episode of anemia that comes for a transfusion? Nodding, but want to say it loud and clear? So how do you explain that?
If the liver is compensating well for the hemolytic process, may not necessarily manifest with jaundice.
If there is enough anemia, will the liver compensate if it is? What is the? You are right in a way, but not completely right. Someone else wants to qualify further on what she said. If it's acute hemolysis, it should cause jaundice. If it's chronic, slow, ongoing hemolysis, you may be able to handle the bilirubin, like she said. So you had to put it correctly, but you said the right thing. So if liver is handling the bilirubin well, you don't get jaundice. So all anemias without jaundice are not necessarily non-hemolytic, and all anemias with jaundice are not necessarily hemolytic. You could have liver disease leading to anemia because of various reasons, multiple factors. So look at the type of bilirubin and then decide whether it is hemolytic or not. Okay?
So we'll examine the baby.
Unless he has some other history in which he wants to bring out something
He said
significant.
after that baby is fine,
No,
till
but
5 years of age.
Other history, growth, development.
Okay, go.
If there is anything significant. Nothing significant. Immunized and
Developmentally
milestones normal.
Milestones normal.
Why are milestones important in such a baby?
Chronic hypoxia may affect the development of the child.
How often you have seen? All thalassemics are intelligent children, Baba. Or even alpha thalassemia children are intelligent children.
Hemolysis may...
NICU, okay, but connectors, but exchange was done on day 2 when jaundice happened.
Phototherapy even after that.
Yeah, so phototherapy, it was in a good setting, I hope.
Yeah.
In a tertiary care hospital?
Yes.
Connectors will not happen if the baby is born in a tertiary care. It should not happen at least. Okay, that's one possibility. What else?
Ma'am, is this a failure to thrive child?
Is this a failure to thrive? No, I'm talking
Because
of
if-
development. बैठिए बैठ जाइए आप भी माँ जी. Failure to thrive and developmental problems are two different things. Don't mix up.
But why did you ask that question? I didn't understand.
The causes of anemia may be different. Following that, the causes of anemia may be different because patient has maybe a patient has not received breastfeed during the initial 10 days. So again, that breastfeeding adequacy may not be poor, and causes of anemia may be different subsequently. First cause of anemia.
So
may
you
be
are
the
trying to
sepsis.
say that
Nutritional anemia should be considered at this stage.
Yeah.
You are saying at 5 months, right? Or so requiring packed red cell transfusions repeatedly. Do you justify that?
Less likely, but
Less likely. But yes, you are right that you have to consider growth, because if growth is compromised means nutrition has not been proper, nutritional anemias can be contributing. So that background you have to keep in the background. But we were talking of milestones. Why are milestones important? Anybody from here? I think we'll leave Kunal a little out for a while. Anybody? Why are milestones important in such a baby?
Is it a syndromic association?
Yeah, you want to know whether there is some storage disorders, some mucopolysaccharidosis like conditions, so many conditions which present early in infancy, but not at birth. Remember one thing, anemia at birth you will not consider it. Hypothyroidism, things like that you will like to know. Okay? So, those things should be also kept in mind. See, why we take a history complete, whether whatever is a presenting complaint. Because every type of condition can have a link to these histories. So you must take a proper history and evaluate and correlate with the present history. So developmental history in this context will give you this kind of information. Okay?
Come now, anybody wants to volunteer and examine this baby? Come quick. Somebody from that side?
Why everybody is scared today to come forward?
Come,
Nobody is
come.
volunteering. Who are the exam goings? We should tell them.
Yeah.
Those who want to pass in first attempt, please come up.
Then there will be 20.
We
Come
don't
on,
have
come
a
on.
Who are
problem.
exam going right now? Amrit has a long way to go.
Very good.
You want to put the baby here? Yeah, she would. She would. We can bring a chair. No, no.
Child is conscious, comfortable, not sick looking,
Cute.
a happy child. Looks adequately nourished for age. There is no evidence of any syndromic facies or abnormal facies. Child has a blue sclera.
You want to tell the mother to undress the baby? ये ऊपर का टी-शर्ट निकाल दीजिए. हाँ. और ये जुराबा भी निकाल दीजिए. See, don't examine when the baby has got so much clothing on her or him, because then you can miss findings. आराम से. Baby's got a respiratory infection right now.
The child is coughing at present.
अंदर nappy है, तो ये भी निकाल देंगे.
So what
Sanitizer
is the
भी है.
interpretation of whatever you observed so far?
पलक.
The child appears to be a healthy child, not sick looking, and active and alert. So presently is not decompensated due to any illness. I would like to go for the systemic examination.
Do you think the baby's skull is normal looking?
Slight frontal bossing is there. Mild
Slight.
frontal bossing.
What is slight?
Amrit,
Slight, even I
Amrit.
had, even you had.
that mic is to be used. We can't hear you.
Don't give it away to him. Put it close.
There is mild, there is frontal bossing, frontoparietal bossing. I would like to look for the continence. The fontanelles are measuring approximately zero point 0.5 by 0.5 centimeters, admitting the tip of the middle finger.
Khasi.
There is no sutural overlapping.
So you're talking of anterior fontanelle or both fontanelle?
Anterior fontanelle. The posterior fontanelle is closed. There is pallor.
How do you look for pallor?
In this age group, we ideally look for pallor in the palms and soles.
So I didn't see you doing it. So do it.
The child is
Do so that everybody learns that technique correctly. How do? You put the palm, open palm of the baby in your own palm and compare with yourself. You see your baby is not very pale, but she's pale. He's pale.
The question here is the blue sclera because of anemia or it's an independent finding?
You want me to answer?
Yes.
Okay.
You're the boss.
Achha. No, some neonates would have blue sclera normally because they have thin sclerae. But in older age group or rather late infancy onwards, we take it as a iron deficiency anemia sign. But in this case, it is not as blue. So it is little thin sclera but not very thin sclera. So I won't really call it blue sclera. It's a normal sclera.
The child is afebrile. Pulse rate is approximate about 120 per minute. Regular in rhythm, rate and character. Bilaterally normal.
The respiratory rate seems to be increased with the subcostal retractions and intercostal retractions, and the child is also coughing, so he most likely has a respiratory infection that has set in.
Respiratory infection involving what parts of the lung?
Terminal bronchioles in the lower part of the lung.
Subcostal retraction, intercostal retraction.
Subcostal are due to the lower lobes and the terminal and respiratory bronchioles.
So airway and parenchyma.
Parenchyma.
Got a good learning for respiratory also. Yeah, Dr. Khare?
Is it respiratory infection or just tachypnea?
The child is also coughing, so we can consider respiratory infection. But otherwise, the child is comfortable.
Bhaiya, but every time there is cough, it need not be infection. No. So let's stop this habit of calling any respiratory symptom as a respiratory infection. Getting the difference, na?
It could be hyperreactive airway disease. It could be just rickets with tachypnea. Okay, because of laryngomalacia, he might be coughing a little. So you don't know what is the reason. You have not examined completely. There's history of fever or not. You have not inquired. So don't jump to conclusions. There is respiratory problem.
No, but your observation that there are intercostal and subcostal retractions is totally awesome. Very good. The other thing is interpretation. So one is infection. The other thing is it could be failure also. No, how do you know?
Cardiac failure in an anemia. Yes, absolutely.
So, but it's good to note that. That's important. Just because there is pallor, you should not miss all these things.
Yeah, go on saying.
There is no, so on superficial palpation, the temperature is normal. There is no tenderness or evidence of any localized collection.
Collection? Guarding or rigidity, if at all you want to say something.
Or rigidity.
Dr. Amrit, this is being recorded for posterity, remember.
We are immortalizing you. So what are you feeling now?
Trying to feel the liver in the spleen. Trying to palpate the liver and spleen.
So what is it? Salman, you want to
Liver
do
is-
it? Let Salman do it. Close that. You go that side. Yeah.
You begin palpating from the right inguinal fossa upwards.
Put the mic closer. Quickly. So did you feel the liver? How much is the liver?
The liver is about 1 to 2 centimeters, and the spleen is about, it is soft, and the margins are rounded. The left lobe was not palpable. In case of the spleen, it's about 2 to 3 centimeters, and it's soft.
Okay, so there is a small liver palpable and a small spleen palpable. Okay.
This is a tachypnic child. So is this liver spleen enlarged or is it pushed down?
So I would like to see the liver span.
So
And
why don't you do it?
I'm getting a dull note in the right 7th or 8th intercostal space. So the liver span is about 3 centimeters and it's not enlarged. 5 centimeters approximately.
So it is normal. What other findings? What other thing you are noticing when the chest is exposed? Yeah, he's got bleeding. So he's got a rachitic rosary, and liver is quite below the costal margin, about 4 centimeters. It's quite big. I mean, it's pushed down probably because of tachypnea, but it's there. And spleen is up till here. Okay, the tip is here. So it is about 3 centimeters spleen and about 4 centimeters liver, but both are soft. Right. Okay. So I think we can discuss now the findings. So what do you make of this now?
कब तक पहना दीजिए और ले लीजिए.
Want her to wait or she can leave? आप जा सकते हैं, लेकिन वो खांसी हो रही है ना, उसके लिए डॉक्टर पूजा को मिल लीजिए. वार्ड में है. हाँ, अपने वार्ड में. हाँ, 37 में. हाँ.
So now, what is the analysis of all your findings? Means after
Thank you.
examining, what
Aryan ki
additional
mummy.
information?
Thank you.
What additional information you got?
We could find that there are features of rickets, one, and there is a hepatosplenomegaly which is soft, which might be either due to push down or because of the present respiratory complaint, or it may be due to the rickets itself.
So you don't think this has got anything to do with the anemia that has
The
been
child
there?
still has anemia, which is seen, looks to be significant, but the child is on medications currently. He's receiving
Did you look at the dorsum of the hands? You missed out, no? You want to call her back? Someone can just call her for a minute. No, you must see that finding, which I also forgot to bring to the notice. Just let her get. Why is it important?
Hyperpigmented knuckle.
Yeah, hyperpigmented knuckles. So what will it tell us?
suggestive of
Directly B12
Megaloblastic.
megaloblastic, nutritional megaloblastic anemia. So directly it gives away the diagnosis, But can this be a part of the hemolytic anemia? The hyperpigmentation?
Yes.
How?
There is a rapid.
Let you. Acha, bol.
Because of hemolysis, there is rapid turnover of new cells coming, and
So what
relative folate deficiency that may lead to
Relative folate deficiency. So folate depletion can happen, and you can get a folate megaloblastic anemia, folate deficiency. I think this baby has hyperpigmentation. 1 minute, Aryan. उसका हाथ. So you see, she has mild hyperpigmentation. He has. It's not very significant, but it is mildly there. Okay? Normally you will not see this portion so pigmented. So there is some hyperpigmentation. So you will keep in mind. What about mother? Dr. Khare is very particular. What about mother? Does she have?
There is mild.
There is mild again. So there is hyperpigmentation in mother and the baby. So what does that tell you?
Points towards a possibility of megaloblastic anemia.
Which megaloblastic now? If mother also has.
Should be B12.
So what history is important? So did you tell about that? You were about to tell, but we didn't allow you to tell. See. You didn't say. I asked you any significant history. You didn't say diet. Okay, dietary history is important in this manner. So you have to find out if mother is pure vegetarian, she would be B12 deficient, then she can pass on the B12 deficiency to the baby. And this baby who started with a low hemoglobin and then became better could again crash because there is no B12. And with a hemolysis that happened, whatever was available gets consumed. Even B12 gets consumed. Folate of course gets consumed fast because folate you require much more. There are no great stores of folate, but B12 we have stores, but if stores were not there, then both will get depleted. So you must think of these conditions also. Anyway, so further what did you do? I think you all can sit, Salman and Amrit. Thank you.
You have any other findings which we have not picked up? Or all the findings were picked up?
Picked up, sir.
So now,
so what's your final
differential,
diagnosis, differential?
5-month-old male infant with anemia, with hepatosplenomegaly, with signs of rickets, with significant birth history of anemia with jaundice, immunized till date, with normal development and no feeding difficulty. I would like to consider exaggerated physiological anemia of infancy, delayed isoimmunization. There may be a congenital infection in mother which contributed to this. Pure red cell aplasia very rarely.
With liver spleen enlarged.
Very rare.
But I think first moot question is we will have to decide whether this enlarged liver spleen is hematologically significant or it's a normal push down liver spleen. That we have to take a call. No, we can't sit on both sides of the fence for one diagnosis and for another diagnosis. So how will you decide that?
With active hemolysis, it is significant.
No. Is it push down liver spleen or there is real enlargement of liver and spleen?
So from your examination, what do you feel from the consistency, span? Do you feel it's an abnormal liver and spleen or it's pushed down?
Liver soft and span is normal, so it is normal liver then.
So you don't feel this is an enlarged liver, right?
Yeah.
What about the spleen also is a push down spleen then?
Spleen consistency is more important. Soft it is.
It is soft. So is it just a push down spleen? Maybe. Well, in the context, I would not leave it as non-significant because if it is, yes, you want to say something.
Normally also the spleen has to enlarge twice its size to be just palpable also. So if it's so significantly palpable, how do we consider it as just to be a push down spleen?
I did not agree. So you are giving your opinion that you won't consider it as push down spleen. Other aspect that you must keep in mind, if you are thinking of a aplasia type of anemia, then the liver spleen are supposed to regress rather than enlarge. In fact, the span should go a little down rather than increase. Now span of 5 to 6 centimeters, it's almost 4 centimeters below costal and 2 centimeters above. So it's 6. 6 is not normal for this age, maybe 5 should be normal. So I would take it as mildly enlarged liver. Spleen is 3 centimeters below costal margin. That's pretty much enlarged because 3 times enlargement will bring it to the below costal. So though it is soft, you will not take it as totally not relevant in the context of this baby. So I'll take it as not a production problem. Once the liver spleen are palpable, I'll rule out a production problem, except if I am thinking that repeat transfusions has caused this liver spleen to enlarge, which can happen with 4 transfusions, 5 transfusions down the line. So these are the 2 things which you'll keep in mind. Actually 4-5 is also too, sorry sir.
I just want to make a point that tachypnea never pushes liver and spleen. Don't bring tachypnea to say liver and spleen is pushed. Unless there is a retention of air, as happens in bronchiolitis. If you have a metabolic acidosis, you don't see a liver and spleen. Why are we considering liver and spleen as pushed down? Unless there is a retention of air. So I don't accept tachypnea with pushed down liver and spleen, but it's the retained air like a bronchiolitis. And this spleen is obviously not just pushed down.
I think sir has put it very nicely in the context, because I was wondering how to explain, but sir you put it there. That if there is no inflation of the lungs, hyperinflation and push down diaphragm, why should liver spleen be pushed? It will come and go if at all. So it should not persist. And therefore, and this spleen is pretty large, and this only helps us to not think of production related problems. Because underproduction will regress almost the spleen and liver. Regress meaning they'll be normal, absolute normal. So they won't be enlarged and palpable. Okay.
Ma'am, about the consistency, which seems to be troubling us.
Yeah.
Can we say it's early days for the liver to become firm and spleen to become firm, and then think of it as pathological?
Absolutely. Presently they are soft, but they might become firm if the pathology continues. And it is quite early step. Yes.
I want to know how well this child has grown. Because this child, you said, has signs of rickets. If you convince me that this child has not grown well, then I'm again a little worried about why you're getting signs of rickets. So would you convince me that this child has grown well and a fastly growing child developing nutritional rickets? If not, then I think we need to bring down rickets and anemia together as well.
Yes.
This child has birth weight of 2.13 kg. Presently at 5 months of age, its birth weight is 5 kg.
His weight is 5 kg.
Sorry, his weight is 5 kg. Apart from the
length
is 61 centimeter against median of 61.8 centimeter. It comes between -3 to -2 standard deviation.
Median and -1, no?
Sorry. Length is 61 centimeter. It comes between -2 to -1 standard deviation. And weight wise 5.2 kg. It again comes between -2 to -1 standard deviation.
No, but this baby is begun with what weight?
2.13.
So don't go by context of only charts. You have to look at the pattern the baby is following. When you plot a chart also, we have been talking of that. Is it following the curve or it is not following the curve is more important. So he's following the curve. He's better than what he started. I'm sure the graph will go upwards rather than downwards. So if it's not going downwards, it's going upwards, I think he's growing very well. I'm happy with the growth. Okay. So sir, now that context of growth and...
Well, I think this growth looked to be normal. Okay. Because this was 2.1 and now something 5. To that extent, I'm a little concerned what was the length at birth as well. We don't know that. 61 looks a little small for 5 months. But I think the weight for length is reasonably alright. So I won't worry about this. I just wanted to bring in a point that a renal disease will have both the rickets and anemia as well. And it's not that both are often together. Renal tubular defects have a rickets and a renal glomerular problems will have anemia. So I wanted you to take a note that renal don't come together unless there is both tubular and glomerular pathology. I just wanted to bring out rickets because it looked like from a distance this child may not have grown well, and I was wondering why this child has rickets. Again, you said the fontanelle was small. What kind of rickets is this when a fontanelle was 0.5 centimeter by 0.5 centimeter? So just to bring in the point that if you have a normal head with no signs of rickets, why are you having signs of rickets everywhere else? It doesn't happen at so early age. It will happen at hypophosphatemic rickets when the skull is alright and the legs are taking brunt, but not this. Just take a note of that. We may be casual about the small anterior fontanelle, but then the question will come in an exam, why are the other signs of rickets present?
Thank you, sir. Sir, you said renal anemia. and renal rickets. But will this age group manifest? Because he's just 5 months old and he's manifesting.
Renal dysplasias, aplasias, etc. Yes. Of course, these children will fail to thrive. But 4 or 5 months is not unusual for a serious renal aplastic kidneys to manifest. But of course, they will have a chronic renal failure. So they would be vomiting, there will be high creatinine, all that. I just wanted to bring down rickets and therefore the renal, etc. I'm sure this child doesn't have any of that.
Yeah, because I don't want them to answer this as your causes of anemia in early infancy. But keep in mind as a background that renal conditions with rickets and anemia can be there in these babies. Okay.
So ma'am, can you now summarize which would be the differentials to consider, and then we'll say how to investigate?
So going by this history of first day anemia followed by jaundice with anemia followed by repeated packed cell transfusions, the first thing that comes to my mind would be an alpha thalassemia, because it's fitting with everything. But I wouldn't rule out enzymopathies and membranopathies on clinical, because you could have a chronic anemia without jaundice, in enzymopathies, in spherocytosis, etc. Liver spleen being present, hemolytic becomes our first diagnosis. Because if there was no liver spleen, my first diagnosis after discounting the day 2 exchange transfusion would be obviously TEC and Diamond-Blackfan anemia. TEC less likely, Diamond-Blackfan higher chance. I would go by these basically. But I won't forget this child has rickets. Mother is a vegetarian, and this anemia has come on after 2 months after the first episode and has been repeatedly there, not improving just with transfusion. I would still consider nutritional element as present. Only thing which goes against nutritional is they don't recur so quickly after a transfusion.
So that's not the primary cause, it's the add-on contribution.
Cause. Yes, so there would be some background hemolysis happening, and then there is a B12 deficiency which is aggravating the anemia, would be more likely than a pure anemia of megaloblastic origin. So these would be my thoughts.
Has this baby been investigated?
Yeah.
Yes.
Can you tell us the investigation reports and then we'll try and interpret them?
Anybody has any other thoughts in mind besides what we have summed up?
Child was presented early, but osteopetro rickets as a little later age group, we may have to...
Large liver spleen.
Large liver spleen.
Yeah, they would have some visual impairment, some of ENT involvement, and they would have larger liver spleens. They would be going down, absolutely, So
and then there are certain elliptocytosis and ovalocytosis with RTAs. So rickets and this. But of course failure to thrive would be one of
So that is what failure to thrive is not there at all. So that whole group goes out. But by itself hereditary elliptocytosis, yes. But they seldom present in neonatal period. Seldom. Spherocytosis is more commonly known to be aggravated by neonatal period, not elliptocytosis as much. Reasons not known why it happens.
Ma'am, I have a doubt.
What must be the cause of anemia on day 1?
Ma'am, I have a doubt that
I can't sometimes orient myself to who's speaking.
The findings are like frontal bossing is there and parietal bossing is there, and AF is very small. So it could be chronic pathology which causing bone marrow compensation, means the production of erythropoiesis. That could be making the changes.
You mean the hemolytic phases that you get in thalassemia?
It could be early changes, means bone marrow is compensating for the anemia.
When do you get in a thal major, beta thalassemia major? When do you get hemolytic phases? By 3 years onwards. Okay. So it takes so long to compensate.
And another finding that ricket precursory, it could be because of chronic tachypnea. It could be because of pull of the diaphragm. So
you don't get just rosary because of
prominence of
I think I'll ask Dr. Chokhani or
you
Dr.
get a Harrison sulcus because of diaphragm pulling, but not a rosary.
Because rosary is actually splaying of the costochondral junctions. So that cannot happen just by pull.
And this baby does not have chronic tachypnea.
It is just recent onset. Mother said 4 to 5 days she's been coughing. So
what must be the cause of day 1 anemia in this?
Sir, I really don't know whether there was a minor group incompatibility because there was jaundice immediately following that. So unless I have reports from that time that Coombs test was done, I will not be able to make out at this point of time. Or unless we review the reports, CBC reports, etc., then we might be able to.
Isoimmune present with jaundice and anemia, and not only anemia. See, the first day presentation was only anemia.
Yeah, I'll explain that. What happens is that placenta is able to handle bilirubin, but does not handle the anemia or rather the antibody. So bilirubin is taken care of in utero by the mother, whereas the antibodies are passed on and the baby suffers from and red cell destruction happens even in utero. As you know, we do in utero transfusions for RHI immunization. So anemia is not handled. So baby can be born with anemia without jaundice.
Wouldn't it have caused hydrops? Such a severe anemia?
I don't know what was the severity. Hydrops will happen if you have 2-3 grams. This might, I don't know, I think it was 12 grams if I remember correctly on day 1. Day 1 CBC is 12 gram hemoglobin?
9.
No, day 1 baby is day 1. Birth. At birth it was 9? 9. So it is significant, but it's not necessary that all babies will develop hydrops. Again, hydrops doesn't happen in every baby because cardiac failure causes the hydrops.
That is because if it's a severe anemia.
Yeah. Significantly severe and non-compensated. So how acutely also it drops matters even in utero.
And other thing what you are saying that probably the exchange was done because of the sepsis. I mean, doing an exchange on second day of life for sepsis is something which doesn't fit.
Hyperbilirubinemia with sepsis, exchange transfusion is a known therapy.
That is there, but on the second day of life.
Yeah, but I don't know if there was already a seeding of organism before birth and the baby is born and has sepsis. I don't know what a neonatologist would do, because I really don't have experience of neonatology. But if anybody else can answer this, I don't know. I just assume that could be the reason. More likely it was anemia with jaundice, so it was a isoimmunization, a minor group incompatibility, which we have not picked up because the blood groups are A positive and O negative in the baby. But minor groups are not done. DCT we don't know, so we really don't have an idea.
Quickly tell us the reports.
Initial investigations also I see.
Yeah, that will be interesting to look at.
Okay. During initial stage, the patient has HB of hemoglobin of 9.
Initial stage means
Day
when
one.
are you talking?
Day 1.
Day 1 of life?
Day 1 of life.
This CBC was...
Yeah. Hemoglobin of 9 with total counts of 64,400 with platelet of 3,12,000 with hematocrit of 24.8 and MCV is 13.7, MCH 49.7 and
MCV is?
Ma'am, MCV is 137, sorry, or MCH is 49.7, MCHC is 36.3 and with RDW which is 12.6 and reticulocyte corresponding is 13.6 with corrected reticulocyte of 6.8% and on smear there is
let's interpret this CBC first. So you said hemoglobin is 9, MCV is 137.8 and RDW is
12.6
12.6 and retic count is 6.6 corrected. How do you interpret this? How would you interpret?
Come on, somebody has to speak quickly. Come on.
I think you'll...
So, ma'am, with the HB of 9 at this age, it's more significant anemia, and the RDW is 12, which is suggestive that the size of the RBCs is quite uniform, and the MCV is 137, which is quite high for this age. So, and platelets are 3.12, so basically it's suggestive of anemia, most likely macrocytic type.
Is 137 macrocytic for day 1? What is the upper limit of normal MCV for a day 1 baby? Full term day 1 baby.
120 to 130.
Around 120, 123 tak hai. So 137 is still high. Okay, so it is a macrocytic, no doubt. But remember, even if you had 100 MCV, it is normal. 110 MCV, it is normal. And that you must keep in mind when you are evaluating a newborn's report. Often we skip that part and say macrocytic. And pathologists also report macrocytic in your impression and give it to you, and you read only that as a pediatrician and you say macrocytic anemia. So don't jump to that. Look at it yourself, what is the age of the baby, and then evaluate with the normograms. There are normograms available. So that point I wanted to bring out from this day 1 CBC. So what do you think is the pathophysiology with macrocytic anemia on day 1? Macro, it is normo upper limit, I would say. Upper limit of norm to significant and non-significant based on requiring transfusion of packed red cells or not. Bleed, which is noticed as something which is causing disorderly bleeding, or rather a bleed which is due to a disorder, is significant bleeding, irrespective of whether I needed a packed red cell transfusion or not. If there is an abnormality in the bleeding pathway and therefore I am getting some bleeding, that is significant bleeding. Okay? Non-significant bleeding is not a good word to use for those bleeds.
Just one second. Announcement. We were offline for some time because of our internet service providers problems. We are back online. The segment of the broadcast which you have missed will be uploaded and you can watch it a little later. And watch it because there was an interesting discussion then. Come on, Salman.
Birth history wise, the mother was registered. There is no history of jaundice or abdominal distension or high colored urine in the child or passage of clay colored stools. Birth history wise, the mother was antenatally registered at 2 months of gestation, has taken injection tetanus twice and has taken iron and folic acid supplements. Antenatal scan was done twice, which was normal.
First we'll finish off the present history, no? You finished with the present history. So summing up what you want to say. Because you asked history of clay colored stools and jaundice. What is the age of the child now?
18 months.
18 months. What is the relevance of this history to the present history?
The kid could have had vitamin K deficiency or could have had a liver disease which manifested with bleeding disorder in the early stages.
Which liver disease will manifest at 18 months with bleeding?
The kid has had this bleeding since he is receiving immunization at every episode.
At every episode of immunization he has had bleeding.
Also had,
and liver disease has not manifested and bleeding has manifested repeatedly.
It could be a vitamin K deficiency.
Which type of vitamin K deficiency? Liver related or otherwise?
Otherwise.
So then liver disease related history becomes irrelevant. Because if you say clay colored stools and jaundice, that baby's got neonatal jaundice, right? Neonatal hepatitis or biliary atresia. Those are significant pathologies which will manifest by themselves before the bleeding.
So you will not come as a presentation with bleeding, but you would have come for the jaundice and those issues.
Exactly. So you should not be taking such a history. It should not become an irrelevant history even if it is possible to theoretically link the two.
Except at one place, at about 6 weeks, 8 weeks of age, if somebody comes with ecchymotic patch for the first time in life, it's the liver disease. And there is no jaundice. Everything is subtle. You do a bilirubin, you will find something. So point is that the bleeding occurs at birth or takes a little time to occur. That 6-8 weeks is a very typical period where the bleeding disorder is rarely due to a primary hematological disorder, but often a liver disease coming up. And if it's a chronic liver disease, one of the functions gets upset first and the others will follow. And many times it's just the ecchymotic patch. And then of course you will find a large liver, and if you do a biochemistry it's already enzymes are high and bilirubin. So that's the only advantage, but doesn't present
with clay colored stools and clay colored stools, and that is a typical history of biliary atresia that you were trying to take. And secondly, sir, I was wondering, till 18 months will he not manifest with liver related?
That's the point. What sir's point was that a one-time 2-month bleeding at different. 2 months may be due to a liver disease. But it goes on at 4 months, 6 months, 8 months without liver coming up is not possible.
So you should not, there itself I come to know that you are lacking in your this correlation of the diagnosis with the symptoms. Yeah?
That particular bleeding is ecchymotic patches and not
only
in the form of gum bleed.
Gum bleed, epistaxis,
so these are two
petechiae.
different branches altogether.
Exactly. Tushar? So that was one aspect which I was little not comfortable with. So I wouldn't ask that. Vitamin K related you will still ask. Again, epistaxis, gum bleeding, would you ask vitamin K related history? No.
So essentially from the history, what do you all make out? What is your thought process? Presentation is gum bleeds, and then there are all those other histories of bleeding. So what do you make out?
Platelet disorder more likely, because mucous membrane bleeding is the initial presentation of platelet disorder mostly. So platelet disorder in form of qualitative defect or quantitative we don't know, but another platelet function, platelet disorder is more likely.
You want to say something?
Or it could be coagulation factors.
So you are saying that you cannot at this point differentiate between coagulation factor defect versus platelet deficiency. Anything that is pointing more towards one or the other in the history?
Yes, ma'am. Following the immunization, he is developing hematomas. That is most goes in favor of coagulation defects.
Okay.
And another point is the minor trauma causing the significant hematomas in the child. So that goes again favor in coagulation.
He's saying platelets.
Rajesh.
You want to?
There is a request. Can you just summarize in 3 lines what the case is so that people
Oh, they can't follow because it was offline before that.
Salman, just in 3 to 4 lines say what the story is so that...
This is a 18-month-old child who has come with history of gum bleeds that subsided on local measures. He has history of bleeding in the form of bleeding post-immunization, has had epistaxis at 6 months of age. He has also had a history of spontaneous development of bluish blackish discolored patches on the skin and reddish spots which was not associated with any pain. There is no history of any significant bleeding disorder in the family in the kid.
Yeah. So you are saying he had mucosal bleeds,
skin and mucosal
he had deep bleeds in the muscle. Okay.
Sir, he had...
I think you have not clarified post-immunization bleed is of what type.
Ecchymosis or it was a hematoma?
Post-immunization he had oozing of blood from the site of immunization, but there was no collection or hematoma formation.
So that is crucial. That is very crucial.
And there are ecchymosis. So then your doubt about it being a coagulation defect is ruled out.
Means you are diagnosing now that it is not a coagulation defect.
It's very likely to be platelets.
So, how can you think of a coagulation defect if there are petty K? Alone, not just, I'm not saying it can be coagulation with platelet, if at all, but more likely platelet because here there is history of only oozing from the prick site and not a hematoma, not a collection, not a swelling. So it is very classical, mucosal and skin bleeds. Petty K is the hallmark of platelet type of bleeding. Yes, you can have von Willebrand disease which might come like a platelet bleed and may also have muscle bleed. Okay, because their coagulant activity of factor VIII is also compromised. Okay, because it's a cofactor for the factor VIII. So that is what, I mean, it's a very straightforward case. I don't think there's much to debate and discuss. Petty K, ecchymosis, mucosal bleeds, classically platelet. Now what we need to think of is, as he rightly said, qualitative or quantitative. Can we make out that on history?
Ma'am, can it be a vascular problem?
Yes, you could have a vascular, but then vascular will not come at this age first of all. Then the type of manifestations which are recurrently epistaxis, gum bleeding is little less likely. Vasculitis will be skin bleeds mainly. Skin petty K are more common than ecchymosis in vascular. Petty K is vascular or platelet. But ecchymosis is platelet or coagulation. So there are these overlap zones. So if we know that, we won't think of vascular in this case. But if it was just skin, I would think of vascular. Of course, you must understand that when you don't examine and think, this is all you can think of. When you examine, you might have some other conditions come into. So a little bit on examination before we go to the further discussion.
Yes. I want to know whether this bleeding child is a sick child or a comfortable, healthy child.
Comfortable, healthy child.
And I think if it's a sick child, then what do you understand by that? He has a platelet defect and he's a sick child. He keeps on getting repeated infections.
Immunodeficiency with
Which immunodeficiency?
Wiskott-Aldrich syndrome can present.
Yeah. So one of the conditions you must think when bleeding has started early in infancy, that whether this child has other features which could be explained on Wiskott-Aldrich, and then the thrombocytopenia is due to that. Okay. So examination?
You get the child and again 2 volunteers to examine.
Who's getting the child?
So, Dr. Salman, what is your clinical impression? What do you feel now after history before examining? So that we have, you put your bets on, then we'll see whether...
Sir, since he has presented with skin and mucosal bleeds and petechiae, most likely looks like a platelet disorder. What type will have to ascertain first?
Why? Will the physical examination tell you
sir,
that?
or investigation?
No.
No. Age-wise and all, you don't want to say? The other evidence?
What do you think it's likely to be? We won't hold a gun against you and say, why did you say that?
Means, let me ask you, for example, the commonest platelet problem that we see is immune thrombocytopenia, ITP. Do you think this is ITP?
Less likely.
Why?
Because he is presented at an early age, there is no preceding symptoms, and the child has been...
Stop at early age. 6 weeks nobody presents with ITP. Okay? But can they have some other immune thrombocytopenia at that age?
Yeah,
alloimmune is?
Neonatal.
Alloimmune is?
In the neonatal period, we can think of alloimmune either because of maternal or the paternal.
Are you saying alloimmune or isoimmune? Both terms are used, but we use isoimmune to make it clear. Okay? So neonatal isoimmune thrombocytopenia, what is the antigens? So like we discussed RH isoimmunization, which are the antigens? HPA1, HPA2, these antigens are there. HPA1 negativity and HPA1 positivity. This is the most common discordance. Even population 98% will have the HPA1. So only 2% are negative. So it's therefore not as common as RH isoimmunization. RH is about 1585, whereas here it is 2 and 98. So it is not a common thing to happen, but once in a while it can happen. This is the commonest isoimmunization. That presents at what age? And what happens to its course? Because if you knew the course, you won't think of that. Yeah, it's generally early neonatal period. Neonatal period going on into early infancy, I would still consider, but it will wane off within 3 months. All antibody mediated which are maternal transmitted will wane off in 3 months. 3 months to 6 months maximum. Some antibodies linger till 6 months. So you must have this clarity and logic, and then you will not consider. Okay. What about neonatal autoimmune thrombocytopenia? Is it possible? As we said, ITP. I refuted it saying 6 weeks onwards he has presented, so I'll not consider. But if it was a neonatal manifestation, then will you refute it? Or what will you think of? Exactly. So if maternal autoimmune is there, it can get transmitted. Very good. So even SLEs will cause immune thrombocytopenia in the baby. Okay? Or mother has ITP in her early life, pregnancy, or even before. Would the mother have thrombocytopenia during pregnancy, and then only the baby will have thrombocytopenia in the newborn period? Would that be a condition to diagnose that? Yes or no? What's the answer? Should the mother also be thrombocytopenic for me to make a diagnosis of ITP in the baby? The maternal transmitted or maternally passed on antibodies. No, it is not a must. Mother may have normal platelet counts and yet the baby can be born with severe thrombocytopenia. The reason being, we are talking of autoimmune, not of isoimmune or alloimmune. The reason being?
IgM type of antibodies.
Not low blood volume, not this type or that type of antibodies. Whatever antibodies are there are circulating in the mother, but they are not destroying platelets. That's all. all ITPs do not necessarily get severe thrombocytopenia. Some ITPs who have higher titers of antibodies also may not have thrombocytopenia. It depends on how much is the clearance of the platelets by the spleen, how hyperfunctional the spleen gets. There are multiple mechanisms by which this whole process happens. So it is not just the antibodies that are present decides whether there will be thrombocytopenia or not. So you may have a mother with no thrombocytopenia but ample antibody in her to pass on to the baby and lead to a autoimmune immune thrombocytopenia.
So ma'am, coming back to this one on history, what would be your differentials?
I don't know, I'll just say platelet type bleeding.
Okay.
And since it has occurred very early in life, likely congenital disorder, that's one thing. Maternally transmitted would have been my diagnosis if I had seen her first time at 6 weeks or 3 months, but no longer now. So it would be clearly a platelet disorder, most likely congenital. So what are the congenital platelet disorders?
Functional disorders of...
No, you classify them rather than... Please. And classify them rather than give names.
Groups or categories.
Yeah, don't give name of the disease. So Glanzmann's you all said, but what is Glanzmann's?
Functional
defect. It's a platelet functional disorder. Qualitative defect. So there are so many. It's only Glanzmann's? Bernard-Soulier. What else? Gray platelet syndrome. Von Willebrand disease. Storage pool defects. So many. So we are not interested in names. Yeah, we are not interested in names. As long as you know this group it belongs to, I am happy. You can always send to the lab and they will give you the actual diagnosis. Okay. Then what second condition you will think of besides platelet functional disorders? Von Willebrand already they said with the platelet functional. Yes, some.
Congenital dysmegakaryopoiesis.
Congenital dysmegakaryopoiesis. Congenital infections torch will come with only bleeding, pure. They'll have multiple problems, no? Multi-system involvement, liver, spleen. Of course, examination we have not touched, but failure to thrive, jaundice sometimes, anemia. So many things might be there. Just bleeding every time, unlikely. This megakaryopoiesis, that is, you are talking of myelodysplasias. Those occur in later life. But any other? Don't tell me you don't know any of the quantitative disorders which are congenital. Micropathic angiopathic. Microangiopathic.
Mechanical stress because of mechanical like prosthetic.
But that's anemia more than thrombocytopenia. There may be thrombocytopenia, but that occurs in 6 weeks onwards for 18 months. Ongoing. See, talk in the context of this child. So in this child we are talking of congenital disorders. One we said qualitative defects. I am asking you which are the quantitative congenital disorders of platelets. TAR, very good. So TAR syndrome. What happens to TAR syndrome is, does this fit? If you have not seen the baby. No, don't look at. We have not examined. So don't look at.
What is the course, madam is asking?
Yeah. Will you consider in this baby? 18 months she still come with bleeds. Yes or no? Anybody knows the course of TAR? So TARs are classically a very good prognostic type of thrombocytopenia. They present in neonatal period onwards. By 1 year they remit. The reasons, mechanisms, nobody knows. They only have to be taken care of for their cosmetic defect of absent radius in later life. That's it. They remit. Okay? So they do very well. So he won't fit because he is bleeding beyond 1 year. What else? Which other?
So there is one input from here. Congenital amegakaryocytic thrombocytopenia.
Okay, so see now you are not answering, other people are answering instead, and that's a good answer. Congenital hypomegakaryocytic or amegakaryocytic thrombocytopenia. Which is what inheritance? Generally it is X-linked, but it can be autosomal recessive also. Okay. Then you have Viscott-Aldrich, which is again X-linked which can be presenting as thrombocytopenia, but you have to go into the details of whether there is some infections, some pulmonary infections, diarrhea, because they also have, what do they have associated?
Immune deficiency.
Immune deficiency of what kind?
IgM deficiency.
What else? T cell defects as well as immunoglobulin defects. So you will look at even that as a possibility, provided you get history of eczema,
skin lesions,
infections, and
seborrheic
dermatitis, and and what else? Ear discharge. These are classical features of viscodilate. So keeping this spectrum in mind of qualitative defects versus quantitative, wherein you have some conditions where there are no associated features, that is amegachromatotic thrombocytopenia, versus viscodilate, which has lot of other associated features, you can narrow down that this child doesn't have that syndromic type of symptoms, so he is out for viscodilate, but the remaining two conditions remain, the broad categories, quantitative defect, qualitative defect. It narrows down from history to this much. So now let's see.
Come, anyone wants to examine, please come. Fresh two candidates.
So Dr. Salman, while they're getting the candidates up here, you tell me, how do I differentiate on size between a petite, purpura, ecchymosis?
Petite is usually less than 0.3 centimeters in size, whereas a purpura is between 0.3 to 1 centimeters, and more than that is an ecchymotic.
Thank you. This was a question online. I'm not harassing you just like that.
Come quickly.
Hello, how do you distinguish between a rash and a purpura?
Yes, that is a very good question.
We used a blanching test. A slide, when applied on the skin, the purpura would disappear, whereas the purpura would still remain, and the rash would disappear.
एक ही साइड से आ रहे हैं और कुछ पहले कभी आए हैं ऐसा नहीं, पहली बार इसको घाट के वापस आ रहे हैं, वो ठीक है, वो देखिए. Now this child has history of ear discharge, bilateral, since last 3 days, which he didn't have before. What do you think now?
Okay.
See how it's dynamic. Medicine is so dynamic, no? It changes every day. So now you will think of viscodilate?
He has not had
a variant of viscodilate should be kept in mind, and that should be your last diagnosis. If you don't find anything else, then last ditch attempt you might think of ruling that out, but not really, because ear discharge in this age group is extremely common. Okay? So you will not take it as something alarming, because no other features, no rashes, no seborrheic dermatitis, no eczema. Yeah.
The child is conscious, not sick looking. Comfortable, no dysmorphic faces.
Growth.
Light so that there's more light.
Well nourished.
क्या हो गया बेटा? क्या हो गया? I think we'll make her sit on the chair down. वही chair ले. नीचे आप कुर्सी पे लेके बैठिए. Put it there.
Push it back.
Backwards. आप नीचे बैठिए. रो रहा है ना?
There are cotton balls in both the ears, probably secondary to a discharge.
Which we have already confirmed that she has a ear discharge. Okay.
So on the background of the history that we got, what all do you want to observe?
Any bleeding points?
So talk about that.
You can ask the mother. She will show you where he's got some spots and.
There's a.
So we can put him. Kunal, let the camera be focused on that. So show that with your finger then.
There's a patch ecmotic on the right side, on the scap, over the back.
These are Mongolian spots.
So they disappear by the first birthday.
No, they don't necessarily disappear in all. Huh?
And one ecmotic patch is also
So
there.
how will you differentiate it from a Mongolian spot?
We'll ask the mother.
हाँ, ये जन्म से है क्या?
So you must ask that history. When did it appear, first of all? Was it always there? And secondly, whatever other spots have been appearing, have they persisted? Were they always there? They come and go. This will tell you the difference.
And there is a changing color.
Evolution, yeah.
Okay, Mongolian spots don't change color. So.
That's fine. So he has ecchymotic patches. Ek minute, huh? Yeah, okay.
There are ecchymotic patches even on the lower limbs, both
Okay.
the sides, on
Okay.
the shin.
Yeah. Any other bleeds?
कुछ लाल,
No, you are examining now. So you're finding any petike?
currently
लाल
no.
लाल है?
नहीं.
नहीं, छोटा छोटा पतला पतला जो लाल आता है. हाँ, इधर एक है. Okay, कान पे. See that on the ear. आप ऐसा ले लो उसको. आप
Yeah,
ऐसा
on
ले
the
लो. On the ear, if you
yeah,
see,
yeah.
there is a petechial bleed here. Yeah. Okay. What else you want to examine besides just looking at the bleeds?
On
Okay.
No, please take the mic. We can't hear you.
Gums.
You like to see the joints. Was there any history related to joint problem? Like?
Ears, nostrils, and gums.
No, for what you want to see? What
Any oozing or
will the oozing continue without it coming out of the nostril or the ear? It's not only bleeds we are looking at. We are also looking at other aspects. So you have to look at other examination also. So joints, you will ask mother history, of course, of joint bleeds, joint swellings. And you will overall examine for any presence of any swellings. Okay? What else you will look at?
Skin manifestations
Like?
like eczema,
Okay,
dermatitis,
that. Okay.
and
Seborrheic dermatitis and eczema.
eczema.
What else?
And
Systemic examination you want to go to?
pallor.
Pallor bhi nahi bola, fundus nahi bola. Huh? You're not looking at anemia, you're not looking at fundus for intraocular bleeds or other retinal bleeds. Those are important, no? So you will do that. What else? Systemic
examination, like to look for per abdominal examination for any spleen or liver.
Do you expect liver, spleen in this child? See, basically you must realize when the history is from 6 weeks to 18 months ongoing off and on, it's unlikely to be a systemic disease related to reticuloendothelial system. And therefore you're not expecting a liver spleen. If you find one, you should wonder why. And then relook at it. But otherwise you are suspecting this to be a pure hematological bleeding disorder. Right? So that is how you must have clarity in mind that I'm not expecting, but I have to complete the examination. So I will look for liver spleen. Suppose you incidentally find liver 2 centimeter spleen just palpable. I don't know what is it in this child, Salman?
Liver 1 centimeter, so
And
spleen is not palpable.
Okay, the reality is it is not palpable. So we will not discuss hypothetical. We will not discuss hypothetical because time is a limitation. Okay, so no liver just palpable, no splenomegaly. Okay, no spleen palpable, I would say. So now what else you want to see? He's crying, yeah. What? Dekhi jao. Thank you. Sambal. So what do you want to say now about this child?
On the general examination, a well child, not sick looking, with the ecchymotic patches seen on all over the body, not present since bluish black patches not present since birth, with the systemic examination being normal.
You don't have to say not present since birth. It's ecchymosis you have confirmed. Then you don't have to qualify. There are petechiae also.
Yeah, the petechiae with no joint swellings.
Okay.
With the systemic examination being normal. Most likely looks like a bleeding disorder, probably because of a platelet, either a quantitative or a qualitative defect.
Which we have already discussed. I think we can...
Yeah.
So,
I want to make a point. Yeah. If this child was anemic, but not sick looking, and we said he has no systemic disorder, then what would you have thought? Many thrombocytopenic patients in our community are also anemic. Then how would you be sure that two are unrelated to each other? You get the question?
So pancytopenia could be B12 deficiency. Pancytopenia could be B12 deficiency.
So I'm just giving you anemia with...
Yeah, we like to examine again abdominal examination, liver, spleen, if it is...
No liver, spleen, just this baby also is anemic.
Could be nutritional.
Could be nutritional. Okay. Are they necessarily...
Chronic bleeding can also present with iron deficiency.
That is what sir wants to probably bring out, that if you have epistaxis and gum bleeds. So you must remember, whatever is an internal bleed, the hemoglobin will be regenerated from the breakdown of RBCs and iron. But whatever is external to the body, like epistaxis, like gum bleeds, these are not recycled because they are out of your body. So there you are losing blood, and chronically even small microscopic amounts of blood, microliters of blood, if you are losing, over time it is going to translate into a significant iron deficiency anemia. So you will consider iron deficiency anemia as a associated feature in a patient like this. But suppose I ruled out iron deficiency anemia, now I am taking this little forward, then what would you have thought of? Autoimmune starting at 6 weeks of age and going on and on for 18 months? Unlikely. Though it's not likely, but there would be what would happen if it was autoimmune to the liver, spleen? They would come up, no? So it is unlikely. What else? Anybody? Can this be Fanconi's? Can this be a constitutional hypoplastic anemia? With thrombocytopenia you will have reticular dysgenesis. There are so many syndromes, but all of them have something typical about them. But you need not always have in Fanconi's a phenotype manifestation. Okay, it could be just bone marrow failure. And generally the age of manifestation is 3 years onwards, 3 to 4 years. But rarely they have reported cases where it starts very early in life. So rarely it will fit in. But by and large you should think of nutritional anemia or iron deficiency due to the blood loss, added on by the actual nutritional element. Because this age group is a typical age group where milk feeding is continued, much more of milk is given through the day and hardly any complementary feeds are given. So all that you must keep in mind together. Okay. So
have you investigated what's your final diagnosis? And
this is a 1.5-year-old male child, case of bleeding disorder, manifesting with skin and mucosal bleeds, with otitis media, with anemia which is mostly nutritional, with normal development and immunization, most likely being a platelet disorder. You'll have to investigate further to rule out a qualitative or a quantitative defect.
So which investigation?
First I would like to do a CBC in this kid. CBC with peripheral smear. In this kid, at presentation, the total count was 8,100 with polymorphs of 28% with 64% lymphocytes, our HB of 9.9 with hematocrit of 28.8, MCV of 78, and platelets on smear were 4.98 lakh. On the peripheral smear, the platelets were not present in clumps. They were normal in size. No large platelets were present.
So what do you make of this CBC and the smear? This CBC and smear, what will you make of? CBC interpret नहीं करते हो, पहले ही peripheral smear पे jump करते हो.
The child has...
Interpret the CBC first, no? Take the mic again. So there is mild anemia, right? Moderate actually. Below 10 we consider moderate anemia. 9.9, so okay, we'll grant mild or moderate. There is anemia. What type of anemia?
It is hypochromic type, means HB is low.
You talk of macro first.
Microcytic hypochromic anemia.
So it is microcytic hypochromic. What else is RDW available?
Yes,
you didn't tell us.
It's 20.5.
So when it's a bleeding disorder, don't miss out on these parameters just because now my focus is only on platelets. I want to look at the RDW because I want to now know this 9.9 grams, is it iron deficiency with the microcytosis or is it some other thalassemia minor or something in this child as a associated inherited defect?
RDW is increased, ma'am.
It is increased. Okay, what else you got from
then
the...
anisocytosis, again it's suggestive of erythropoiesis is going on.
You have anisocytosis also in the peripheral smear?
It's normochromic, hypochromic and microcytic. This is not mentioned.
Mentioned, okay. But there is definitely anisocytosis if RDW is 20 and you have a microhypoanemia. This is looking like a iron deficiency anemia. Now you can put 2 and 2 together that this child, what is his reason for iron deficiency is probably blood loss, but also probably improper diet. So dietary history still remains important even in a case of platelet disorder. Don't do away with it. Yes, now coming to the platelet count.
It is not in clumps.
Count. See, you're already biased. They've heard that and they are biased. What is the platelet count?
4.98 lakhs.
4.9 lakhs. Normal, abnormal?
Normal.
Normal, increased.
More than
you must
normal.
Make that point that it is mildly increased platelet count. Not thrombocytosis, it's mildly increased platelet count. Why are we interested in this platelet count being normal, increased? It's not low, that we have ruled out.
To see for the production, means bone marrow.
Quantitative defects would have.
Or qualitative.
So quantitative is ruled out if it is not low. But why are we interested in whether it is high?
Iron deficiency anemia per se.
Again, iron deficiency anemia per se. What else? In this context of this child.
Functional.
It's bleeding, no? Every time. So what does it do?
Compensatory.
Sends a signal to the marrow to produce more platelets. Okay, so you get a reactive thrombocytosis, which is not so much in this baby actually. Or it could be the microcytes of the RBCs which are counted as platelets in the counter. So either of these reasons you could explain why there is a slightly increased platelet count. And then now let's come to the peripheral smear. What does it tell you? Peripheral smear? He already said that,
he
no?
He said size and shape of the platelets are normal and they are not seen in clumps.
So what does that tell us?
That means it is...
Would you have liked him to tell you some more parameters on the CBC? He just limited it to... You should ask for that. What else you want? Newer parameters. Today's PTW doesn't help so much. IPF. What is IPF? Why you want to know that? How does it help us?
Ma'am, we didn't hear what IPF is.
Yeah, immature platelet fraction. They didn't hear, you mean? Okay. So, what is the value of immature platelet fraction? How does it help us?
It tells us about the marrow functioning, whether it is the production is adequate or not. One is that, and if there is destruction outside, the IPF will increase.
Okay. What it tells you is that the marrow is producing platelets continuously and in a faster turnover. So when you have peripheral destruction, the IPF increases. Normal ranges for children have not yet been derived, they are under research, but by and large 4 to 12 is normal range percent. Beyond that is considered high. So if you have a more than 12% IPF, you must consider this as a peripheral destruction with a faster turnover. That means marrow is functional and there is peripheral destruction. This is what you must remember. In this context, what will happen to IPF? You don't have platelets in clumps on the smear. So you are suspecting a functional defect. So what will happen to the IPF?
Should be normal.
It should be high. There is all the time signal going to the, when there is bleeding happening in a child with platelet functional disorder, a signal is being sent to the marrow to produce more platelets, and those therefore will be immature platelets which will come into the circulation and you'll have a higher IPF. So that marker helps. MPV, how does it help?
About the size of the platelet.
How does it help? But what is the MPV?
It's 9.5.
9.5. Now tell me, interpretation. It's normal. So what does it tell me?
It rules out certain disorders which have increased platelet size. So
okay. Microplatelets it rules out for sure. Okay, so you don't have Viscott-Aldrich in this child most likely. Is it ruled out 100%?
It has a variant which has large megaplatelets.
Yeah, so, but those are very few cases, rare cases. By and large, classical Viscott-Aldrich should have a microplatelet syndrome, whereas megaplatelets are seen in variants of Viscott-Aldrich, which you need not worry. At least let's know the typical classical variant. Okay, then what about looking at the PDW? How does that help us? Platelet distribution width, how does that help us?
Immature platelets are usually large in size,
Yeah.
so wide PDW suggests of increased formation of new platelets.
It's just like anisocytosis in RBCs. If you have varied sizes of platelets, you will get a wider PDW. If they are all normal kinds, in the normal range, you will have a normal PDW. Okay. So PDW doesn't give us too much information because by and large the MPV gives us the information about immature platelets. Like reticulocytes, immature platelets will give you the information of marrow activity. Remember that much. Immature platelet fraction is a corollary to reticulocytes of the RBCs. Okay, fine. So what more you did? So what will you do if you find peripheral smear showing platelets not in clumps? I say this is not abnormal. I want to be sure. What is the question I will ask my technician or my resident doctor?
EDTA smear.
Yeah, okay. So what did you make this smear from EDTA blood? If you have made it from EDTA, what will happen? There will be no clumps anyway. So that is important part you have to ask. And you must therefore make a direct smear always, irrespective of what is the reason for the smear. Whether it's for MP or whether it is for routine CBC evaluation, iron deficiency anemia, because incidentally you may pick up these cases. And always look at platelets from this point of view, whether they are in clumps or not. Once you see a large clump, you know quantitatively, qualitatively, they are normal. Okay? If you see EDTA smear, you will not be able to make this interpretation. Okay, now the platelets are not in clumps, and I have confirmed with my resident doctor that this was a direct finger prick smear or direct blood from the syringe. Okay, before putting into the bulb. And it is a non-EDTA smear. What do I do? Yeah, I think mic चाहिए था आपको. Oh, there was a mic there.
Platelet aggregation studies.
So, what aggregation you do?
Cystostatin, ADP agonist.
Okay. What else? What else? What are the various substances?
ADP, collagen, epinephrine.
ADP, collagen, epinephrine, ristocetin, thrombin. These are the common substances with which you look at aggregation. Okay. Now, what is platelet aggregation going to tell you when you do this testing? Because this case has that relevance, we'll just discuss for a minute about this. Yeah, we'll wind up. What will you look for? You add these substances and look for aggregation. And now you have aggregometers which are automated, which give you graphs of aggregation. So if you have low aggregation with one of these substances or more, then you know there is an aggregation defect. So which substance will give you non-aggregation in different types of platelet functional disorders? I think someone who knows can just speak it out.
Ristocetin would, a patient of Bernard-Soulier syndrome won't have aggregation with ristocetin.
Okay.
Whereas a patient with Glasband's thrombasthenia will manifest with aggregation on ristocetin.
But you have to say with what it will not, because with ristocetin can be also normal person.
Collagen, ADP,
collagen, epinephrine will be abnormal in Glanzmann's thrombasthenia, and aggregation with ristocetin will be abnormal in Bernard-Soulier syndrome as well as von Willebrand's disease. If you remember this much, good enough, you will score your marks in exams for sure. In practice, you refer the patients to us beyond this. Okay? And what is the treatment? Treatment? You should know the treatment. We have to advise this mother, no? What is the inheritance? Autosomal recessive. What is the treatment? And what do we do? Prenatal diagnosis in the next child or no? Is a prenatal diagnosis advised? It's not advised. Because it is not a very severe disease by and large. Yes, some people can have severe bleeding, but bleeding can be taken care of. How do you take care? Yeah, platelet transfusions. Repeated platelet transfusions causes refractoriness. What do I do? What do I do? Only give transfusions first of all when there is a life-threatening bleed or a severe bleed, significantly severe bleed. Otherwise, do not transfuse. Like this present problems that he has, you don't have to transfuse him. He's got just ecchymosis, petechiae, that's all right. Just explain to the mother, this is going to come and go, come and go. Don't worry about it. To counsel properly. Otherwise, they keep wondering, diagnose किया है लेकिन आप कुछ कर नहीं रहे. So you have to tell them, इसमें कुछ कर नहीं सकते except when there is a significantly severe bleed. So if we do not have significantly severe bleeds, we are not going to do much. But if we have repeated significantly severe bleeds, which happens in some of these patients, you will give them platelet transfusions. Avoid random donor platelets. Give single donor platelets. Identify a single donor who will keep donating every time this patient bleeds and call the same donor. So that will avoid alloimmunization. In today's times, it is possible and feasible to do this. If patient becomes still refractory and does not respond, you may use sometimes factor 7, that is recombinant factor 7, Novo 7 what we call, because that has an extremely, good and quick action. Within 2 hours, patient stops bleeding. We have treated for 2-3 patients with that and they've done extremely well. And they don't need it again and again. If you once have treated the patient, explain to them at the onset of epistaxis, please bring your child here quickly, and then you can give platelet transfusions from the single donor. Okay, so this is, I think, the management of thrombosine.
How do you match the donor for platelet transfusion? For blood transfusion, you do a lot of matching. No? How do you do that?
Not required. Not required.
Why not required? They have an antigen.
Not required. Required? What you'll... ABO-RH matching should be done ideally because they express... ABO should be matched because ABO antigen, RH is not expressed on platelets. ABO is expressed on platelets. So you have to do ABO... you must give ABO matched platelet transfusions always. Avoid non-ABO because platelets itself will get broken down if you do not give ABO matched. Okay? And of course, avoid red cell contamination in the platelet pack also, at every cost. Okay, don't give too much of RBCs in that.
And what's the general course of these patients?
I have had about 6 to 8 patients who have grown up to be normal. During menstruation, they have trouble. During deliveries, they have trouble if they are female children. So, male children, by and large, they will do quite well because there will be minor bleeds here and there and they'll go through it. But if they undergo surgery, they must take precautions that platelets should be available which are not refractory, so matched platelets preferably again, and single donor. If they are not undergoing any surgeries in life, they shouldn't have problem. They'll have a normal lifespan. But females have trouble. During menses, we often put them on the hormonal therapy to reduce the amount of bleeding that happens. And this becomes a difficult thing because it is lifelong almost all the time. So some of them don't take and they stop it on their own. Some of them develop side effects, though there are very low estrogen containing medications available now. By and large, there are no side effects. So this is how we manage them.
Anand, any questions or should we stop?
Yeah, we stop with a couple of statements from this end. So firstly, ma'am, thank you so much for conducting such a beautiful session.
Thank you.
It was really enjoyable, and I think this is one episode we would like to watch again and again and again. I'm sorry for the disruption in between, but you can watch it again when you can watch it offline from the same page. The next broadcast is going to be from Kanchi Kamakoti Child's Trust Hospital on the 12th of August. It will start at 2:30 p.m. Dr. Balasubramaniam will be conducting it, and I have a suspicion that there are going to be cardiology cases. So tune in and have fun. Thank you so much.